Today's topic, moving the needle with I2B2, a translational research tool for accessing clinical data. I didn't pick this title. I'm not sure what kind of needle they're referring to, whether it's the kind that goes like this or the kind that goes like that. But what we're gonna do today is talk about access to clinical data through a self-service tool called I2B2, which is a repository of clinical data that mostly comes from the electronic health record. And we have been encouraging people to use this. We had a contest a few months ago. We had an award ceremony last month to give a prize to the best abstract for people who had used the tool. And we are going to do that again, probably hopefully this year. And we will, so maybe you'll pay attention when you find out you could win $1,000 if you figure out how to use this tool and answer some interesting research question. So what we have today are three brief project descriptions for people that did use I2B2 to produce data and develop an abstract, hopefully go on to publish some interesting studies. But let me ask first, how many people know what I2B2 is? Everybody, except one or two. And you know what it is. Okay, so I'll just go very quickly. So I knew if I asked who doesn't know, nobody would raise their hand. All right, so Impact, our Cerner, our electronic health record tool, we pull data out of there, goes into our enterprise data warehouse. A researcher wants to get access to those data, and they go through an enterprise data warehouse analyst, a human being who has a big backlog of work, and so they get to your request, and you talk to them and say, I need these data, and 2 weeks later he comes back and says, okay, I got you the data. You go, no, that's not what I wanted to say. Well, that's what you said. Well, no, I didn't. Yes, you did. And they sit down and figure it out. Again, they go back 2 weeks later and come back, and now, oh yeah, that's almost it, but could you add one more thing or two more things? And they go back and forth like this. And so the researcher has to go through that route, and it's sort of a necessary process sometimes. But by putting the data into I2B2, we allow researchers to go and get the data directly. So now they can argue with themselves about whether they got what they wanted or not. And then when they get the data, they get initial data, then they may decide, oh, now I need additional data that's not in I2B2. Now they can go back to the analyst and say, okay, I figured out which people I'm interested in, but now I need more data on those people that's not in I2B2. So for example, the discharge summaries or the progress notes, things like that. And so I2B2 can be used in kind of this whole cycle, and we'll go through this from thinking up an idea and wondering if we have any patients that have this condition to, looking and seeing if there's a correlation that looks like it might be interesting, developing a study, figuring out who to recruit for a study, and eventually getting your data and writing it up and coming up with a new idea based on the study that you did. So it's a nice cycle of research. Okay, so we have three presentations today. Let me just get to the first one. So Abdullah Al-Anazi is actually was the winner of the I2B2 contest, and so he's going to present his work first. So Abdullah. So which one is you? This one? Okay. And just so you know, got your forward and back. If you wanted to circle something, just hit the top button. Or you can use those. Yeah.
Hello, I am Abdullah from the PhD program in Rehabilitation Science at the School of Health Profession.
And I'm so sorry, I got to put the mic on.
Oh, there's a microphone there.
I'm sorry. Yeah, but here.
If you're going to move around.
I'm so sorry. Yes. Especially for people online. We have a bunch of people online. So, sorry.
Thank you for that.
You can just put this in your pocket.
Yeah, sure.
Or hold on to it, or however you want to do it.
Okay.
All right, go ahead. Sorry about that, guys. Go ahead.
Hello again. So I'm from PhD program in Rehabilitation Science at the School of Health Profession. I work with Dr. Eric Ford. He's from School of Public Health. I am kind of interested in smoking behaviors and what other risky factors that engage in smoking and smoking and vaping. Recently, that was added to this behavior. Smoking is such a complicated behavior to be understood, and how to resolve or decrease the prevalence of this behavior. A lot of factors contribute to this behavior. So we were thinking of developing a project about how different risk behaviors increase the initiation of other behaviors, or maybe it might be a tool of cessation to other smoking choices like tobacco smoking or vaping. One of the big risk factors that engage with the smoking is substance product. other illicit substance abuse. So this is how we initiated our like thinking of like bigger project. Back in the literature with this tobacco smoking, smokers are more likely than non-smokers to be engaged in other risky behaviors, such as illicit substances like heroin, cocaine, amphetamine, and etc., especially illicit substance abuse in the black market, etc. Recently, since the inception of electronic cigarettes in the US market, vaping companies were invading the US market with a new product of as they're like hypothesize or like as they assume it's like there is harm reduction with it, which is vaping, electronic cigarette or e-cigarette, or like in the electronic nicotine delivery system. Anyway, these are a new product in the market. They propose this is reduce the harm of tobacco product, different chemical, carcinogenic chemicals, etc., with the cigarette itself. What's in the electronic cigarettes? It's nicotine and different additives that produce the flavor and the aroma, etc. It's unclear how different substance abuse, different substance products increase the initiation of vaping, or like is vaping as a smoking, is it like cessation tool for this illicit substance abuse? If someone is really addicted or like to heroin or cocaine or etc., do they use electronic cigarette as cessation tool, or just this is a gateway to engage in different risky behaviors? This is when I sit with Dr. Eric Ford up there that we came up with like doing mindstorming, came up with different questions. How clear is the relationship between electronic cigarette and substance abuse? Is the availability of like electronic cigarette increase the risk for other forms of substance abuse? Can effective documentation of electronic cigarette in the hospital can be as a risk factor for other negative health behavior, that we can track other negative health behavior since we are documenting people who are using or self-reporting using electronic cigarette? How informative if we compare the electronic cigarette and traditional combustible tobacco cigarette to the use of substance abuse? Is there significant difference in substance abuse proportion between cigarette and electronic cigarette? There, when Dr. Eric Ford introduced me to I2B2, that we can track information, we can have data from the system. Is there really difference between vaping and smoking? Do people who vape use illicit substance abuse or not? This is when we came with our study question. What's the proportion of current and former substance abuse with individual who self-report use of electronic cigarette or tobacco smoking? We did our study design. We used the I2B2 system of UAB to generate smoking and electronic cigarette use, current substance abuse, and former substance abuse rates from our system, from UAB system. That's a single institution overview. Our method, we have electronic cigarettes, since it was recently invading the market. UAB system starts screening for electronic cigarettes since September 1st. So September 1st, 2017, officially they were documenting electronic cigarette use whenever they have outpatient, an outpatient clinic or ER or inpatient, etc. They were screening for electronic cigarettes since September 1st. So we controlled the time between tobacco smokers and electronic cigarettes from September 1st until like recently, February 21st. Then we analyzed 200, in the system we have 200 something with electronic cigarette and 3,000 smokers in the sample. We did two sample z-test proportion analysis as to perform the proportion of different use. At that time, our finding, we found almost 227 electronic cigarette users from September 1st. Tobacco smokers 3,700, and current substance abuse around 2,400. Former substance abuse around 2018. We have almost like equal distribution in gender between male and female, ethnicity. We still, in comparison between being African American as a minority, still there is high use of like abuse of electronic cigarette and substance abuse with African American individuals. Our findings, so we kind of separated the substance abuse to three groups. First, we identified that who are currently reporting that they have current substance abuse issue. And also we identified who have or reported former substance abuse issue. Then we compared all of them together. We found that the percentage of people who use electronic cigarettes is higher than people who reported using smoking. So between these two groups, the current substance abuse is higher among people who vape, which is a significant difference between smoking. And also we found that even with former substance abusers, they tend to use electronic cigarettes. So it could be in this way that using electronic cigarettes as a cessation tool, as it's proposed in the literature as well. And also in general, there is a difference between people who smoke and people who reported using electronic cigarettes. I mean, since it's like just a data, just the system, there are a lot of limitations to this data. It could be there is a shared area between maybe sorry, individuals who reported vaping, also individuals who smoke as well. So we might have a shared area between smoking and vaping as well. But that does not mean that still the proportion of individuals who reported using electronic cigarettes and people who engage in substance abuse, it's really high. And this is something we can track from here in the future. Especially like vaping and substance abuse, it's a public health issue, and it's really a critical public health issue. So we can track such a behavior. This will be helpful. I mean, especially when you have gone to your system and trying to identify which patient reporting these issues, and then longitudinally identify their initiation of such a behavior, what are their perspective and belief about different smoking product as a cessation tool, or like just initiation to different behaviors. We concluded that, as I mentioned, that proportion of electronic cigarette and other substance abuse is greater than the proportion of tobacco smokers and substance abuse. This study is a cross-sectional design, make the causal inference possible. So one possibility is substance abuse. People who report in substance abuse using electronic cigarette as a cessation tool, or people who reported using electronic cigarette, this is serve them as a gateway to use other riskier behaviors. So it could be bidirectional, either from vaping to further down the road with severe other risky behaviors, or it could be something beneficiary that we can identify and take benefit of, and identify individuals who use electronic cigarette as a cessation tool and give them help and provide them with support. So understanding a temporal initiation pattern among these products is a critical design to effectively to have effective intervention. Future research, future direction, collecting longitudinal data to identify substance abuse pathway in terms of both initiation and cessation. A question to include, are electronic cigarettes increase the smoking initiation? So is it as a claim that electronic cigarettes increase smoking cessation or smoking initiation, which is could be bidirectional? Or are electronic cigarettes an effective tool to promote cessation of other substances, like legal or illegal? Is there systematic demographic, like socioeconomic disparities among people who use electronic cigarettes? So could we identify specific demographic data? Is there socioeconomic distribution or disparities between different users that we can have a specific intervention to that group? Mainly, this is our find. This is our like future direction, and this is how we use the I2B2 system to track this information and get this hypothesis. Eventually, we'd like to thank people as the Information Institute. They were very helpful. They were, I mean, responding very fast. They were there whenever we approached them. So thank you for you people, and any questions, guys.
For your questions. Everybody online, if you could please mute yourself. Everybody who is online on GoToMeeting, whether you're on your phone or your device, please mute yourself. If they call in on the phone, then that's, I muted everybody else and it was still there, so somebody called them on their phone.
Okay, question.
Sure.
So it seems like, I don't know for sure, but, oh, thanks. Vaping might be something that's kind of skews young, and that smoking is something that people may be doing, I don't know, they don't try vaping because they've been smoking for a long time or something. So the real question is, so I understand that birth dates would probably be, or age information would be protected. and that you wouldn't have been able to tap that. But is that
Yes.
something you might look at in
Uh,
future research?
in smoking behaviors, what we really, it's interesting that either like individuals are teenagers, like younger than 18 or older than 18. This is a major distribution because if they are teenagers, there are different behaviors that we can track and different like intervention that we can aim to. For example, schools, parents, etc. Older than 18, it's different world. I mean, we have very big distribution. So age, it could be like, it's really important to control, but to generate an idea, it's not that, I mean, critical to consider at this time, but in down the road, absolutely, it should be controlled, yes.
So just to clarify, I2B2 produces what we call limited data sets, which have most identifiers removed, but the dates are still in there. So we have birth dates, so you can get birth dates, and you can get other dates, and that relates to my question, which is because the dates are in there, and I realize the number of people was relatively small, you could actually look and see if using e-cigarettes leads to other things, or whether the people who are already abusing drugs then start using cigarettes.
Yes, yeah.
That is, you could look at the chronological relationship because you do have the time, of course.
Yes,
the numbers are small, and we may not have enough historical data.
Yes.
But it would be another thing to look at.
So as I mentioned, that screening was so recent, like
Right.
6
Right.
months or so.
That's
This is
another-
why just generating the idea.
And of course, how long have e-cigarettes been around? 4 or 5 years.
And the US market since 2011.
Oh, okay.
2011, yeah.
Okay.
So
Yeah.
you're telling us we can get panel data on the individuals to look at their,
You can get individual data, yeah. Individual.
okay, after you do I2B2, you send in a request.
No, I2B, you can download individual level data from I2B2. Yep. It's you have to fill out a little form, and you have to have signed off on the data use agreement in advance. So these are all steps that you would do with the IRB if you were getting a limited data set. Only we get the sort of a generic data use agreement established initially. You reassert that you agree to that at the time you're going to do the download, and then fill in other information that you would normally provide to the IRB, and then you get the data right away. You don't have to wait for approval. The approval is automatic, assuming that you're following appropriate practices. Okay, thank you very much.
Sure.
You didn't present any averages, so I couldn't make a stupid ends justify the means joke. Where am I? Which one is me? Oh, you know what? Let's just go to the next one. So the next one is Wolfgang Mühlhofer. Did I pronounce that correctly? Which
Right.
one is him? Is this him?
That's the one.
This is it? Okay, good. Okay, and he's an assistant professor at UAB Epilepsy Center in the Department of Neurology.
Just right here. All right. I guess everyone can hear me okay? Okay, good. So thank you again for the invite. I'm kind of a little bit of a hybrid, I think. I actually use the data warehouse as well as the I2D2 tool, so you'll see how I actually was able to retrieve individual patient data from the I2B2 data set too. So that's a nice kind of addition to this. So I wanted to talk about the next 10 minutes or so about duration of therapeutic coma and outcome of refractory status epilepticus, which has been kind of my research interest even in fellowship. That's why there is a data set also from UCSF where I did my fellowship in there. And, to kind of give just a brief background about, some of the terminology that I'm using, I just wanted to give an introduction here. So status epilepticus is defined as, either a generalized tonic-clonic seizure that lasts longer than 5 minutes, or a cluster of seizures in between the patient doesn't recover full consciousness or has a neurological baseline. And in this situation, within the first 5 to 10 minutes, really the first responders are on site, and 911 is typically called when EMS arrives. That time window is a little bit generous, but typically when they arrive on site, they stabilize the patient and give first-line treatment for status epilepticus, which is benzodiazepines. Predominantly lorazepam and midazolam has very good data that it works preventing status from progressing. Then they were typically transported to the ER, where they arrive, and if they still have seizures despite benzodiazepine administration and reverse of acutely reversible causes, they start a second-line agent, which is an IV anticonvulsants. Typically, the ones that are available is fosphenytoin, valproate, as well as Keppra, levetiracetam. And if the seizure then still goes on, that's really when, and repetitive dosing of benzodiazepines doesn't stop it, that's really when the patient tends to get intubated and placed on a sedation protocol with, more commonly using propofol and midazolam here as basically third-line treatment. At that time, as you can see up here, patients typically get hooked up to an EEG monitoring system. So we check for non-convulsive seizures, because typically patients stop seizing physically, but there's still electrographic seizure activity on the EEG. And this is basically the level of refractory status epilepticus, so a status epilepticus that hasn't responded to benzodiazepines or second-line treatment that requires intubation and sedation. And the interesting part is that, there's reasonable data to suggest that actually potential brain damage, certainly in convulsive status, but even in non-convulsive status epilepticus, can start as early as 10 minutes, 15 minutes, sometimes 30 minutes into a seizure. So the earlier you treat, the better, but I'm kind of on the other end of the spectrum here right now. Status epilepticus is the second most common neurological emergency. The incidence is high and is on the rise the older our population gets. About 30 to 40% of these patients progress into refractory status epilepticus, and it's not a secret that it's associated with worse outcomes, prolonged hospitalizations, moderate to severe disability, post-status epilepticus epilepsy, and increased mortality compared to patients that are well controlled. These are the treatment guidelines of the major neurological societies, the Neurocritical Care Society, the European Federation of Neurology Societies, and the American Epilepsy Society, which is the most recent one, that all have the therapeutic coma as part of their guidelines, but none of these, if you look at their wording, really is very specific about the duration of coma. It's based on expert opinion, and typically is anywhere from 24 to 48 hours. The therapeutic coma, what are we talking about when this happens? So this is just a timeline here on the bottom in hours, and the top is just a dose of anesthetic, the variable units. And what really happens when a patient gets intubated, and the EEG up here shows a seizure like this, they start ramping up the anesthetic, as you see here, until you get suppression of seizure activity on the EEG. And that's when the level of anesthetic is kept steady until it's time to wake the patient up, which is anywhere between 24 to 48 hours. And then the EEG gets monitored during that period of time so that you can sense seizure recurrence early on, even if it's not clinically available. So my therapeutic coma is, or the therapeutic coma as I defined it in my research question, is basically consistent with a stable maximal dose of anesthetic. So from the beginning to the end, the end of the titration to the beginning of the taper, that defines the therapeutic coma kind of time window. So studies on treatment of therapeutic coma are, majority of them are retrospective. There's only one very small prospective trial that basically failed to enroll enough patients. It was multi-centered, and it's really challenging in a neurological emergency to enroll patients. But they basically compared primarily the efficacy of different anesthetic agents as well as the depth of anesthesia for seizure control and functional outcome. And pretty much all of them kind of summarize that regardless of what anesthetic you use, if you suppress the EEG background deep enough and early on, that provides you best chance to have immediate and sustained seizure control. The durations here varied actually quite a bit, not necessarily consistent with the current guidelines, anywhere from 24 to 96 hours. And only one study looked at durations of therapeutic coma more than 20 hours being associated with poor outcomes and deaths. So none of these studies actually looked at seizure control, sustained seizure control in relation to duration of therapeutic coma. And yet there is a lot of data out there to say that we might actually do these patients more harm than good by putting them under anesthesia. Multiple retrospective studies showed that these prolonged hospitalization increase the risk of infection, disability upon discharge, and death. Even though this is quite controversial, and more recent multi-centered studies said, okay, patients tend to be longer intubated and in ICU, but they don't necessarily have worse outcome due to that. So my hypothesis really came into from the aspect that therapeutic coma is effective for refractory status, but it bears risks for in-hospital mortality and morbidity, and so it is important to optimize that therapeutic coma and in order to maximize benefits and minimize treatment exposure-related risks. So my study design was a retrospective observational cohort study. I enrolled adult patients only that were admitted to the UCSF and UAB Medical Center from 2009 to 2016 for refractory status epilepticus. I excluded patients that had post-anoxic status epilepticus. All of them were treated with first, second line agent, intubated and sedated, either on a mono or combination therapy of these anesthetic agents, propofol, midazolam, and pentobarbital. And my predictor was duration of therapeutic coma, as it was defined as a surrogate using the maximum dose of anesthetic. The primary outcome was seizure recurrence, either clinical or on the continuous EEG monitoring within the first 48 hours of lightening of sedation, which is considered to be a withdrawal seizure in the literature. Secondary outcomes that I looked at was in-hospital complications, the standard complications that we encounter, hospital-associated or a ventilator-associated pneumonia, deep vein thrombosis, stroke, myocardial infarction, sepsis, critical illness, myopathy, and neuropathy. I looked at disposition and functional status upon disposition, whether patients went to rehab or actually long-term care facilities, duration of ventilation, length of stay and ICU stay, as well as mortality, which was defined either death in the hospital or discharge to hospice or comfort care, which was sometimes also the case. So how did I actually recruit my study patients? So as I said, it was a hybrid approach. I did use the I2D2 search tool using, this is kind of a screenshot, using ICD-9 and 10 codes for status epilepticus, combining them with the procedure codes for long-term monitoring, EEG monitoring, as well as drugs that are commonly used to produce anesthesia in these patients. And this actually provided me a list of 230 patients. And I was able to acquire the medical record, the date of birth, as well as the date of admission through the data warehouse. Actually, Robert Johnson helped me with that. And the other approach was through the data warehouse directly with Robert Johnson, looking at anesthetics in combination with long-term EEG procedure notes and inpatient localization, primarily ICU and neurology floors, which gave me another 101 patients. From UCSF, I simply searched the entire time frame for ICD-9 billing codes for status epilepticus, which was about 384. So summing this up, and I'm going to go over this very quickly, is we had 715 patients. I screened them. 66 were post-anoxic. 30 were multiple admissions. And the left 619 distinct patients. And 63 of that had an incomplete data set. As you saw, we required a lot of data, but especially therapeutic coma was not well documented. 374 were well controlled on first and second line, so that left 182 distinct patients, about 30% of the data set that I initially acquired, that were fitting the enrollment criteria. So looking at the demographics and comorbidities on these patients, in the bivariant analysis, there were no significant differences, without going into much detail. as you see here, we looked at previous history of seizures, status epilepticus, anti-seizure drugs prior to admission, but also the Charleston Comorbidity Index and modified ranking scale. So we looked at indications for morbidity and functional status prior to admission. When we looked at the clinical presentation and details of treatment, this is a pretty busy slide, but the ones that kind of stuck out in the bivariant analysis was if patients received additional anticonvulsants or anti-seizure medications during hospitalization, they were more likely to be in the seizure recurrence group than in the no seizure recurrence group. The same was actually, interestingly, for prolonged therapeutic coma. Now, some people can say, okay, well, these patients on EEG, they have a horrible looking EEG, and I suspect that they will cease, so I keep them in burst suppression longer than the other group that does better. But we actually looked at epileptiform abnormalities on the long-term monitoring, and as you can see, there's no significant difference between those two cohorts. We also looked at seizure severity scores that take into account the clinical presentation of patients, the status epilepticus severity score, as well as the epidemiologically and morbidity status epilepticus score, which really take into account a lot of factors like age, clinical presentation, etiology, and between those two groups, again, there was no significant difference. So these patients were, for some reason, treated longer, but they were not necessarily clinically or due to clinical judgment. When we looked at the seizure recurrence on multivariate analysis, we found that duration of therapeutic coma was not independent predictor of seizure recurrence. Actually, we looked at another factor, which is other treatment modalities, such as immunomodulating agents and things like that for more advanced super-refractory status, and that is an independent predictor for seizure recurrence, which is not too surprising because these agents really come into play when you have very refractory status. So overall, in the multivariate analysis, this was our primary predictor was not independent predictor for seizure recurrence. In-hospital complications, we did a multivariate analysis here. There was actually some interesting factor other than trials of therapeutic coma, which was borderline significant, but maximum dose of the anesthetic agent actually reduced the likelihood of having in-hospital complications. And that's actually supported in the literature when you look at early studies. When you have patients in a very deep coma, you have better outcomes. You tend to have better outcomes even though you prolong ventilation. These maximum doses might really relate to that a deep coma actually is something that might be beneficial for these patients to reduce complications. Functional outcomes, there are two things, age at admission and modified ranking scale at admission. That these are significant is not too surprising. Older patients that are pre-morbid, just going to do worse after such an admission. But the other thing was, aspect was seizure recurrence. So patients that did have seizure recurrence tend to have a poor functional outcome in the multivariate analysis, so an independent predictor. So that tells you you've got to control these seizures. You have to be very aggressive actually up front to improve their outcome. And then we actually did an ROC curve and an index analysis of therapeutic coma against different outcomes to see whether we could be able to define a treatment window, a therapeutic window that provides sustained seizure control, but also limits morbidity and mortality in these patients. And as you see that here, actually, might be even better to do it this way. Here you see, the ROC curve for sustained seizure control or seizure recurrence, yes or no. And the cutoff here was 35 hours, providing a 48% sensitivity and specificity of 77% to predict seizure recurrence. With morbidity, will mean in-hospital complications, this cutoff was at 20 hours. And then when you look at functional neurological outcomes such as independent survivor of refractory status epilepticus, then we are at 10 hours, while mortality, so means survivors versus death, we were at 17 hours. Now, some of these ROC curves are, not as pretty as you would like them to, and that is certainly probably in part related to the fact that we're not having as many patients. But, just looking at the data, this is a little bit oversimplified here, but I just wanted to kind of get the point across. When you look at the timeline of therapeutic coma for patients, then you have this 35-hour cutoff of sustained seizure control and seizure recurrence, the 20-hour cutoff of uncomplicated hospitalizations versus in-hospital complications, then the 17 hours between survival and death, and the 10 hours between a good functional outcome and a poor functional outcome. And that kind of compared to the current recommendations of 24 to 48 hours, you kind of see that our optimal time window for this patient cohort is actually shifted more leftward. Will mean that a shorter duration, might actually be the better optimum compared to the expert opinion or the current recommendations. So just to conclude, therapeutic coma is an effective but risky treatment for refractory status epilepticus. We found that it's not an independent risk factor for seizure recurrence, mortality, poor functional outcome, or in-hospital complications, which is interesting and somewhat different from previous studies. We saw that seizure recurrence yet is an independent risk factor for poor functional outcomes, so prompt and sustained seizure control is important in this cohort. A high dose of anesthetic or deeper therapeutic coma might decrease the risk for in-hospital complication in this patient cohort. So is a more aggressive treatment up front actually the right way to go? And then the most effective and safest time for this cohort lay between 10 and 35 hours, which is shifted somewhat leftward towards the current recommendation. So are we actually treating these patients too long and not aggressive enough up front? Than what this cohort or this retrospective study kind of suggests. So the limitations are somewhat obvious. It's a retrospective study, so we are looking at associations, not necessarily causation, and there is certainly an extraction bias. Some patients were intubated and started on treatment prior to transfer to major tertiary care centers, so there could be an underestimation of treatment duration. Patients were sometimes just intubated for airway protection, not necessarily for treatment of therapeutic coma. So they could have had a complete seizure control even before they were started, so there could be a bias in there. We were not able to verify the burst suppression, or the duration of these in actual EEG tracings because these recordings are typically cut in pieces and stored separately. And the ICD-9 codes are primarily looking at convulsive status and not as much as non-convulsive status patients. I was kind of able to bypass that with the help of the data warehouse people and by searching different parameters. But ICD-9 codes are definitely underestimating non-convulsive status epilepticus. So future perspectives, I think the key feature to all medical treatments and management questions is a randomized controlled trial with a higher patient number. And I'm hoping that some of this preliminary data will kind of lead to an ultimate funding for a multi-center trial. I'm also working on using that data set because it's entered in a REDCOD database, and you can do a lot of different things on a scoring system that might predict seizure recurrence to help guide the management of these patients. And that just leaves my thank you to my two mentors, Dr. Lervenstein and Saflarsky at UAB and UCSF, Stephen Layfield, a research assistant medical student at UAB, Paul from the statistician department here, and Robert here from the CCTS informatics department, and Shalini, who helped me with the REDCap database. And that's it. Thank you.
Time for one question.
Sorry, yeah, I went over time.
No,
I know.
That's fine. Okay.
Overwhelming.
Okay, thank you.
Well, thanks. All right, there you go.
So one question is more a comment. So you got data from UCSF as well. And while we don't have a relationship with UCSF, we do have establishing networks with other
I2B2 sites that you will actually be able to go to in a version of I2B2 that looks the same, called Shrine. It'll allow you to get data automatically from multiple sites, although currently it'll only be summary data.
Oh.
But eventually we're in the ACT network, and that's something like 60 sites. You'll be able to go in there and get detailed data. The other comment I wanted to make was your slide that showed all those terms. It was a big list of terms, and you had 3 sets there, at least, and showing maybe you have more. We're working on improving the I2B2 ontology so that you'll just be able to go, get me all the status epilepticus cases, and that will subsume all the detailed terms. So you won't have to go, gee, do I need this one? Do I need that one? You'll just go, get me this one. And it's frustrating the way it's currently configured, but and everybody in the country or the world that uses I2B2 has the same problem. But UAB is going to fix it, and seriously, for everybody. So stay tuned. Okay, our last speaker is Morgan Dew, who's a nurse clinician in pediatric surgery, is it? Neurosurgeon, and who's going to speak on pregnancies in women with spina bifida.
I'll just stand there.
Okay, great. Okay.
Hi, my name is Morgan. I'm with neurosurgery at Children's of Alabama. I work specifically with Dr. Jeffrey Boyle. Today I wanted to talk to you about pregnancies in women with spina bifida and how we used I2B2 to get our data. First up, I want to talk to you about what exactly spina bifida is, because not everyone knows. Spina bifida actually means open spine. It's a spinal cord malformation that happens during the first month of pregnancy and is also the most commonly permanently disabling defect in the United States. Also want you to know that spina bifida happens at different levels of the spine, not just one. It can happen thoracic, it can happen cervical, thoracic, lumbar, and also sacral. Pregnancies with women in spina bifida is a project that we started about 1.5 years ago. It's a prospective qualitative study looking into the process of pregnancy in women with spina bifida. This particular study is not well researched. There's not a lot of data out there, so we wanted to explore, because we have 2 clinics, one at Children's and one at UAB, which are both multiple disciplinary, and the children start at UAB and then start at Children's and then move up to UAB. So we follow them through the lifespan. For this particular study, we had 14 spina bifida patients who had successful pregnancies, in which 6 of them so far have been contacted and agreed to participate in our study. We did this study through phone interviews, chart review, and then enhancement with the I2B2 data. This poster that you see right here was presented at the Spina Bifida World Congress 2017 in San Diego, California. Again, we're looking at women with spina bifida who have become pregnant. We were mainly focusing on what happens during that pregnancy. And the reason that we only have 14 right now, it might sound like a small number to you all, but in this particular patient population, they are unaware that they can carry and conceive children. So for them to have 14 patients who have done it here just with the UAB system is a really big deal, especially to our patient population. So using I2B2, we had additionally 4 patients, bumping our number from original of 10 to 14 patients. We used questions that involved if they were intending to get pregnant, how many times they had become pregnant, how many children they had, if they were using folic acid during their pregnancy, how their mobility and continence and bowel management was, how if it declined or improved during their pregnancy, and if their child who they delivered had a neural tube defect themselves, which I can say none of them did. Sorry. Using the I2B2, I wanted to kind of walk you through the process of what we did and how we used it. Most important thing when you do is when you sign in is use the find tool and search by name for us in particular, which you can see here circled in black. And then we wanted to use specific keywords in order to get our first group. We specifically looked at spina bifida and made sure to include any myelomeningocele code. Because what we noticed is with your drop-down screen, there was multiple codes for spina bifida. And we also made sure that we chose the diagnosis code and not the procedure code. And this helped our codes to expand. The second group that we also wanted to look at to kind of make this more specific was pregnancy, obstetrics, and abortion. We cross-referenced these with our keywords to make our list more concise. The next step that we did was we ran the query, which you can see here circled in black, and then our results were 10 with this particular group of keywords. Prior to using the I2B2 system, our group tediously went through every electronic medical record of all of our adult spina bifida patients that were women at the UAB clinic, and it took several days. Using the I2B2 system, we were able to get these patients within 2 minutes, which you can see here we found 4 additional patients. After doing your query, what we did is we sent our IRB approval in order to get our data set and the patient list back to us, and it was a really short time frame. We got that list within 5 days, and that list was in form of Excel spreadsheet, which I know someone earlier had asked what exactly were the variables that were provided to us, and you can see here we had the medical record, last name, their phone number, their birth date, sex, and so forth. One of the features that we found in I2B2 that was really beneficial to us was the option of using and not only an or. It allowed us to be more general, but then allowed our results to become more specific, which you can see here circled in black are ands. Another feature that we liked about I2B2 was the unique ability to query the entire UAB medical record, which is a big deal to us. It also allowed you to review and run past queries from the previous sessions that we had done, so we didn't have to redo our work each time, which you can see here circled in red. The most beneficial benefit of I2B2 that we had is the speed. Again, what took us several days, we were able to do in just moments. And as this technology continues to improve, our research efforts are going to get better and quicker. And then this infrastructure, it allows us potentially to collaborate with other people, which we would love it if we could collaborate with children's in the future. Some challenges that we face with I2B2 is that you have to be a UAB employee to access this, which I'm a children's employee, so I had to rely on my group to help me get access to this. Another thing is that it requires familiarity before becoming proficient. You have to take a course for I2B2 in order to use it. And then, again, some of our patients that we initially went through were not included in the I2B2 data that we were provided back. So there were some that overlapped, but then there were some that I2B2 missed, and there are some that we missed that I2B2 caught. Next up for our research project. So we're going to continue with the pregnancies in women with spina bifida, conducting our phone interviews with the ones that we found through the I2B2 data. We're also extending our study to include the future patients at UAB. Like we said, there were 4 patients through that I2B2 set that we did not know that we do not follow through our UAB system, so that we're going to invite them to come to our adult multidisciplinary clinic so we don't miss them as well as extending and continuing a biannual I2B2 search to pick up other patients that might be lost through the loopholes or that we're just not aware of. And then we're also in the process of writing the manuscript of our pregnancy with women in spina bifida with hopes to improve clinical teaching related to pregnancy and sexual health education. And my acknowledgements, you see here Betsy Hobson, who's with Children's and UAB, Dr. Blount, Dr. Rock, Dr. Biggio, Dr. McLean, Anastasia, Nadine Bradley, another nurse with our department, Anna Graham, and Catherine Zimmerman. Thank you.